We'll get started today. Hello, I'm Esteban Regalado, Director of Physician Education at Telix Pharmaceuticals, and we'd like to thank the AUA for this opportunity to present a webinar on advanced imaging for prostate cancer. This presentation is titled Gallium-68 PSMA-11 PET-CT Imaging for the Detection of Prostate Cancer. Today, I'm happy to recognize and invite Dr. Umesh Oza, who is a nuclear medicine physician in Dallas, Texas, who is currently Chief of Nuclear Medicine at Baylor University Medical Center in Dallas, also is Chair of Radiology at Baylor University Medical Center in Dallas. Dr. Umesh Oza is an experienced radiologist in the interpretive services for PET-CT. This presentation is intended to provide information about an FDA-approved drug to a physician in clinical practice. This webinar is intended to be educational, and any presentation or rebroadcast of this requires Telix Pharmaceutical approval. Dr. Oza is a paid consultant with Telix Pharmaceuticals.
Thank you, Esteban, for that warm welcome and introduction. I'll take it from here and let's start with the basics. So this is the package insert, and let's go over the indications and usage of gallium-68 PSMA-11. So the top three, or the three indicated reasons to do this examination, are: one, a patient with suspected metastasis or candidate for initial definitive therapy; two, suspected recurrence based on an elevated PSA level; and three is for the selection of patients with metastatic prostate carcinoma for which lutetium-177 therapy is indicated. Like with any pharmaceutical or drugs, there are warnings and precautions. A few of them I want to just highlight. One is that a negative image or a negative examination does not necessarily rule out the presence of prostate carcinoma, and nor does a positive image definitively confirm prostate carcinoma. We do know that non-malignant processes such as Paget's disease, fibrous dysplasia, and osteophytosis can also take up the tracer. As everything, we must correlate with the clinical picture and may include histopathological evaluation. So there's some radiation risk whenever you give any kind of radiopharmaceutical or use PET as well as CT, so that needs to be kept in mind when we're clinically practicing, and it adds to the overall long-term cumulative radiation exposure of the patient. Adverse reactions can also occur, but very minimum. They're low grade, and they've been reported as nausea, diarrhea, and dizziness, occurring at a rate of less than 1% of the time we administered this radiopharmaceutical. In a large study, the VISION study, over 1,000 patients received this radiopharmaceutical, and the adverse reactions were very low. And again, the mild ones: fatigue, nausea, constipation, and vomiting. As with any radiopharmaceutical or drug interactions may also occur. Patients who are on androgen deprivation therapy, also known as ADT, and receive gallium-68 PSMA-11, we do not exactly know what the interaction can be, so that's something to keep in mind as we use this radiotracer. I also want to highlight a relatively newly approved radiopharmaceutical that we're excited to present today as well, and it's Gozellix. And it is indicated for two things right now. And currently, the third indication that PSMA-11 Illuccix has not been approved. So number one, it's suspected metastasis who are candidates for initial definitive therapy, and two, suspected recurrence based on an elevated PSA level. As with PSMA-11, we also have the risk of positive lesions that may represent Paget's disease, fibrous dysplasia, and osteophytosis. And the converse, a negative study doesn't exactly always rule out the presence of prostate carcinoma. And we also know that the safety aspects of this Gozellix also mirrors what we've seen with PSMA-11. One of the advantages of Gozellix is the longer shelf life, and I'll get to that in a few slides. But the reason we have that higher shelf life is we've added some additives to the solution to allow for that. And there has been reported hypersensitivity reactions to the sulfites that are in that solution. So that is something to be kept in mind. It's generally a low prevalence. We don't know exactly the number, but that's something to be keeping in mind. And again, with the adverse reactions were low, overall nausea, diarrhea, dizziness at a rate of less than 1%. As with PSMA-11, we must keep in mind ADT and its effect or potential effect on the actual radiopharmaceutical being bound by prostate carcinoma malignant cells. So, as mentioned earlier, the advantage that Gozellix has over other fluorinated-based tracers at a standard dose. Let's first look in the top of this slide where it says the highest dose. If we're giving 10 millicuries of our F18, the end window is about halfway through this line. With 7 millicuries, which is the highest dose we suggest for Gozellix, it has a longer injection window. In fact, it's 113% longer injection window than a comparable F18 highest dose administration. But what if we gave it in the sort of the standard dose? Again, the standard dose for fluorinated 18 PSMA radiopharmaceuticals is about 9 millicuries versus 6 millicuries for Gozellix. And so that radiopharmaceutical, look at the window that we have all the way out to here, and it's about 240% larger window. Again, these are in minutes. So again, it gives you a longest time to dose expiration, i.e. shelf life, than any other gallium-based PET agent that incorporates cyclotron-based gallium-68. And sort of if we can just sit back and sort of look at a big picture, why Gozellix kind of gives you this greater advantage. And the two words you want to think about are anytime and anywhere. So anytime, flexible dosing, not tethered to a production schedule. There's no window of availability. We can get it in the mornings, on weekends, extended hours. Great on-time dose arrival, greater than 99%. And then doses are available in 15-minute time slots. If you have a very high volume practice and you need to dose patients and have them sit and have the uptake before they scan. And of course, the longest time to dose expiration of any gallium-68-based PET agent that uses cyclotron-based 68 gallium is the advantage there. And anywhere, meaning that because of cyclotron production, you can virtually supply gallium-68 almost anywhere in the country or wherever you may be. Generator production offers seamless scalability. You get more and more doses as you need, as we mentioned, the 15-minute time slots. And then dual production, whether you're doing cyclotron or generator produced, gives you really just a net of availability, meaning large cities to remote areas. We can sort of cover those patients as well as those imaging centers very well. And then, if your practice grows, the radiopharmaceutical, both of them allow for that growth. You directly order from local pharmacies, radiopharmacies that is, and then the reliable production in over 230 radiopharmacies nationwide. We'll cover that again at the end. So great anywhere and anytime sort of summary there for our new Gozellix. And now let's get over and get an overview of what PSMA really is and how we target it. So PSMA is expressed or overexpressed either 100 times or 1,000 times more in 95% of prostate carcinoma cells. And there's more detection in prostate carcinoma lesions with PSA of less than 1 nanograms per milliliter than CT imaging and bone scan. We know that there's been studied. Conventional imaging, as we say, for CT and bone scans is less sensitive than our PSMA PET CTs. And the degree of PSMA expression positively correlates with tumor stage, higher risk of recurrence, advanced stages of prostate carcinoma, the Gleason score and grade, as well as overall poor prognosis. So the higher the intensity, the higher the SUV measurements, the more number of lesions, all these things correlate with these 5 sort of higher clinical aggressiveness of this tumor, and it's listed there for you. So let's look at gallium-68's molecular structure. It's made out of amino acids, mimic the substrate of actual PSMA. And so it allows for high affinity binding on the extracellular domain of PSMA. And as we know, we radiolabeled this structure, PSMA-11, with gallium-68, which allows for on-site tracer production in a generator and overall lower radiation exposure from its shorter half-life, which is about 68 minutes. There are other agents out there. There are ones that are made with F18, and of course, the one we're talking about today was gallium-68. And so you have to be careful with both. You have to understand the positive aspects of one and maybe some false positives of the other. And one of the things that has been highlighted by the Society of Nuclear Medicine and Molecular Imaging is this idea of free F18. So stepping back, the fluorinated 18 agents have F18 bound to an agent that binds PSMA, much like gallium-68 PSMA-11 does. But what if that F18 broke off? That's called defluorination. And if that broke off, that will be called free F18. And that F18 circulates in the body and binds to something. In fact, it likes to bind to bone lesions. And so this free F18 and the high affinity of bone lesions for F18 could cause and does cause false positives. In fact, as I mentioned, SMMI has in their procedure guidelines suggested that in interpreting bone lesions with F18-based PSMA radiotracers can be challenging due to the detection of benign bone lesions because of this defluorinated F18. Something to keep in mind when interpreting these studies or choosing which agent you want to have in your facility based on the positives and negatives of each of the agents. So, imaging agents and radiation exposure. We know if you turn on the news, you read on the internet, radiation exposure is an important part of medicine. The second most common radiation exposure to the general population is medical radiation exposure. A lot of it's CT scanning. So, looking at two different radiopharmaceuticals, we'll talk about Illuccix, which is the PSMA-11 agent. At a standard dose of 5 millicuries, the radiation exposure is about 3.1 millisieverts. And if you compare that to the standard dose of, let's just say, Polarify, which is 9 millicuries is the standard dose, it's about 3.86 millisieverts. So if you look at gallium-68 compared to F18, gallium-68 provides an effective radiation dose to the patient of almost 20% less than fluorinated agent that we're looking at here. So something to keep in mind. To give you an idea, about 3 millisieverts is about what we receive in background radiation. If you live in the United States, mostly at sea level, in a year, you probably receive about 3 millisieverts in your life. So that's what we're comparing it to or sort of keeping it a reference. But again, gallium-68, almost 20% less radiation exposure, effective radiation dose than a fluorinated agent.
Dr. Oza, a question for you related to radiation exposure. The general public is well aware of generally the cumulative effects of radiation, but how important is this to the healthcare provider and the patients receiving these radiopharmaceuticals? What concern level is there really?
Absolutely. It's definitely front of mind for us when we're choosing, whether to image or not, number one. And number two, when we select an agent, we want to make sure it's got everything we need to diagnose or restage or select for lutetium-177 therapy. But we also want to make sure it's not harming the patient unnecessarily. Now, radiation is radiation. We're already giving 3.1 millisieverts with this agent we're discussing today. But if there's a chance, and this patient may get a staging and a restaging, study over years of follow-up, if there's a chance of reducing it by 20%, I think most radiologists or nuclear medicine physicians would also consider that when selecting agents or selecting which agent we want to use. And patients are aware. They have full access to their medical records. They have the full access to the internet. And they can look any of these things up and ask the question to their clinician, which may filter back. Well, obviously, will filter back to our expertise, radiologists, nuclear radiologists, as well as nuclear medicine physicians. So, yeah, I think it's an important concept, an important idea, in fact, to keep in mind in practice.
Thank you.
So we've talked a lot about the basics, a little bit about radiation, a little bit about safety. Let's look at where this tracer sort of lines up in the patient. So I get to talk about images, which is always fun for me. So on the right side of your screen or image there, we have the biodistribution. Biodistribution is just a fancy term for where will this agent go if there was no disease in this individual. So there's always physiologic activity, and that physiologic activity in the head and neck binds to lacrimal glands, which is the area in the side of your eyes that generates tears. We've got these two things on the side of the face. Those are salivary glands. We exercise those a little bit when we eat, particularly if you have something sour. Those will really, or salty, will really activate and secrete, but will actually bind this gallium-68 agent. And then coming down in the thorax, less activity, just some blood pool activity. Then we get to the abdomen, which contains the liver and the spleen, and then the colon. There's a little bit of activity in the colon. And then it's excreted by the kidneys. So urinary activity you'll see in the collecting systems, the ureter, and then of course it pools in the bladder. So that's where all the activity ends up in the pelvis, eventually trying to get out of the body. So that's really the biodistribution, and normal uptake in the prostate is very low, which allows for us to identify if there is focally increased uptake. We can actually see it. The same thing in the brain. There's really no uptake in the brain. It's like no activity. So if there unfortunately is small focus of activity, you start thinking, could this be a metastasis or other brain lesion? When do we use PSMA-11? What are the time points? Now, we look at those three indications we covered in the beginning of this presentation. And number one is the current indication would be initial staging prior to definitive therapy in patients with suspected metastases. So that's the first sort of indication. The second is, unfortunately, these people will receive definitive treatment, and some of them will never require another PSMA PET-CT. Their PSA level stays low, and they're just followed that way. But sometimes there is a biochemical recurrence or a suggestion of recurrence, and then that's the second indication, a suspected recurrence. They'll get more treatment. They may get metastatic castrate-resistant disease with time. And again, from left to right, we're talking about time. They go through therapies, and then they become eligible. And we're talking about PSMA-11, the Illuccix agents. But the third indication would be for selection for radioligand therapy, which is the lutetium-177 therapy for these patients. So that gives you sort of a timeline and sort of overview of when PSMA PET-CT would be indicated. Now, I mentioned conventional imaging, and that conventional imaging would include CT scans and then bone scans, which we have all who have practiced long enough seen and been replaced by PSMA PET-CT. And just to give you numbers, PSMA PET-CT sensitivity for these patients is about 85% compared to 38% in conventional imaging. Specificity, once we see a lesion, is it really prostate carcinoma? And that's a very high number, near 100% for our PSMA agent, and then about 91% for conventional imaging. Then if you take some more of this data and say, how accurate is this examination? We're talking 92% compared to 65% in conventional imaging. So we talked about conventional imaging. What about MRI of the pelvis? So multiparametric MRI of the pelvis is pretty standard of care for our patients who are diagnosed with prostate carcinoma. And so how does the data from looking at multiparametric MRI compared to PSMA PET-CT? So these patients had an average PSA level of 8.6, so a little bit higher PSA, and we're looking for localized disease. So the sensitivity, PET-CT, 95%, multiparametric MRI, about 86% in this paper. And then what about the tumor size that we missed? Meaning, what's the threshold at which we can actually see a lesion? So look at gallium-68 PSMA-11. It's about 0.72 centimeters cubed versus, meaning we can see down to that size, right? At 0.8, we're seeing it. At 0.72, we're not seeing it. For multiparametric MRI, it had to be 1.66 or greater for the MRI to detect it. So under that, let's just say 1.2 centimeter size lesion, centimeters cubed, would not be seen by MRI, but would be seen by PSMA. So pretty powerful information there. And then what about extracapsular detection sensitivity? And for PSMA-11, that's 78%. And multiparametric MRI, it's down to 54%. So that's an interesting, because in my practice, MRI is pretty standard for our patients getting staged for local disease once they're diagnosed with prostate carcinoma. To see the power of PSMA-11 compared to NP-MRI or multiparametric MRI is really interesting and fascinating. So we're going to look a little bit about some phase 3 clinical trial data, safety and diagnostic performance next, both in Illuccix and Gozellix. So the slide title here is High Performance at Low PSA Value. I mean, it's a very powerful title in that finding patients' disease at low PSA numbers is very important. So we don't wait too long when the PSA is too high and then detect disease. And we have a great surrogate marker in PSA that we can follow in these patients. So the performance at low PSA. So if we start way left on this bar graph here, less than 0.25 PSA, we're about 45%. Up to 0.5 PSA, we're at 50%. And you can go up on this slide and read it. And it's anything over, once we're at 10, or really once we're at greater than 2, we're in the 90s, right? 90, 93, 96. So 2 seems to be the PSA cutoff where we're going to, 90% of the time, we're going to find positivity in the scan. And then if we look at the PSA levels and then look at where we're finding disease, and if it's an interesting correlation here, as the PSA gets higher, you're seeing more in the prostate bed, right? It seems mostly getting higher. At 5, it looks like it dips down a little bit. Pelvic nodes kind of has a variability. We're actually seeing a lot of pelvic nodes at less than 0.5 compared to a higher PSA level, which makes sense because now it's multiple regions. So that encompasses some of those nodes there. So this is a nice display of what we're going to see and where we're going to see it. And knowing that prostate bed, nodal, extrapelvic non-bone, meaning other nodes or maybe lung or liver, and then bone, and then multiple regions, multiple of these sites. These are the places we're looking as radiologists and nuclear medicine physicians. These are sort of the target areas. We're looking at everything on the scan, but we're really targeting those regions. So we're seeing, even at this low 0.5, we're going to see things outside the pelvis and maybe bone, where it's now metastatic, or multiple regions at low PSA levels. So that's very interesting data there to review.
Dr. Oza, a question here is kind of interesting, given your practice reads so many of these scans and you really get referrals from a broad group of urologists and others and oncologists in your area. What have you been seeing in terms of physicians ordering the PET CT, the PSMA PET CT at a low PSA, meaning something really low, like under 1? Do you see that a lot? Is that becoming common?
Yeah, great question, Esteban. Yes, absolutely. We have patients who had a low point or a nadir that's, very low, 0.1 or even 0 or undetectable. In those patients, right, when they get up to 0.25 or zero point 0.5, the urologist or the rad onc or the oncologist now think there's disease. There's evidence of it. There's biochemical evidence that there's some prostate cell making this PSA. And so they'll order the scan. And initially they used to call and ask, what's a good PSA level? Where should we do it? At what level should we do the PSMA PET CT? But they have been seeing, after we read the scans, at positivity at less than 1, which is amazing, because generally I would say to my clinical colleagues, under 1 PSA, there's about a 50% chance we're going to see something. So there's a 50% positivity. And so to patients who are nervous and they have prostate carcinoma, acknowledge they want to know if it's back or not in treatment, it seems like they want to know. And those patients who want to know will push for that. And obviously it's a clinical decision as well. And the clinicians will order it less than that. So I've seen a lot more PSMA PET CTs order very low PSAs. And again, 50% of the time I'll find something. That's about what I see in clinical practice. But it's pretty powerful, because at conventional imaging, we probably struggle to find some disease we can actually definitively point to as real recurrence or real metastatic disease.
Yeah, thank you, Dr. Oza.
Of course. So this is a great image. Again, we're back to images to show the diagnostic value at low PSA levels. So let's start with patient A. All right. Patient A is here. This is the MIP image. We're doing head to toe in normal biodistribution. We've got a red arrow pointing to us, and we're going to say, okay, where is that? And so this patient had a 0.1 PSA, right? We're not talking 0.5, we're talking 0.1. And this image shows a bright orange spot here on the fused images, and on this PET image is that an arrowhead has a little spot there. We know that's in the prostate bed. So that is local recurrence at a very low PSA. Patient B, again, standing up head to toe, or head to thighs down here. We got a red arrowhead pointing out here. That's kind of not in midline. This was kind of in the midline over here. So it's outside of the prostate bed. And as we know, we talked about in previous slides, we're talking nodes or bones or things like that. So most likely either a node or bone. And we look to our fused image here, and we see that arrowhead pointing to this very small dot here in the left hemipelvis. And on the PET only image, a bright black spot, or a dark spot there. And that's a small node. And if I was reading the CT scan, I would never call this pathologic. It's too small. But on our PET scan, we're showing it. And this patient had a PSA of 0.13. So again, just to show you the power of it at those low PSA levels. Now, we know the positivity rate probably in this range would have been 50% chance of seeing something, but very powerful image to show local recurrence and then a nodal recurrence in the left pelvis. So now we're going to get into some cases, and I'll show you a little bit of history on some of them. Some we don't have a lot of history, but show you just sort of the breadth of what we see when we use these, when we image with PSMA-11. So just to orient you, top left here is transaxial image, meaning just cutting the patient like short slices, making like a donut through the patient. And we're going to have CT image, which are these bright sort of bones here and muscle and skin over here in the prostate gland, and the fused sort of the PET image layered on top. So you have two things seen at one time. We call those fused or fusion images. And so hot spots will be this brighter orangey yellow in finding. And then low areas won't have much uptake, and you can see through it and see the CT image. And then over here is coronal, seeing it from the nose to the back of the head. These images are sagittal, sort of cutting left to right or right to left. So on this image, we've got a 69-year-old male with new diagnosis of prostate carcinoma. It looks like Gleason 9, which is a higher level. PSA on this patient was 21. We gave about 6 millicuries of the agent and did almost a 60-minute uptake. And now we see the primary tumor. We're not surprised because we're path-proven, biopsy-proven Gleason 9 cancer. And so that hot area is in the prostate bed. If I was reading this live, I'd go up and down and see what the capsule's doing, if we're having extracapsular spread. Is it going into the rectum, which is important for the clinician to know? And then I'd scroll around looking for nodes, and we're not really seeing anything here highlighted. But we do see something on this image here. I mentioned earlier we had the CT and the PET here. So over here, this bright thing in the middle back area is the spine. And so this is the L5 vertebral body. I know because we're getting into the sacrum here, and I've got a coronal image that sort of confirms that, and a sagittal image here showing that hot spot there. So this bright, tiny little orange spot here is a metastatic lesion in the L5 vertebral body. I believe we have one more slide to sort of highlight that particular finding, or both of these findings. So again, prostate bed recurrence on your left, or staging, I apologize, and then the L5 vertebral body hotspot there. So we don't have a pure CT image to show you if there's a sporadic lesion or a lytic lesion or no lesion. But in my practice, I've seen many times where we have a hot spot, we know it's a metastatic lesion, but there's really nothing on the CT to comment on. Again, reaffirming what we talked about earlier, that conventional imaging sometimes will miss these lesions, and PSMA-11 is very powerful. So what about in biochemical recurrence? This patient was 65 years old at the time of the scan, had a prostatectomy about 6 years prior, and his PSA bumped from 0.18 to 0.21. And so this biochemical recurrence, we're going to do a PET CT. And so here's a PET CT image here. And now this is nicely, we had our arrowhead earlier. Now we have a circular point out of a magenta or purple color here. That's a small image here, but we actually had an MRI performed right before the scan, and we use the MRI, and we're going to sort of look at this and sort of correlate it. And somewhere in the pre-sacral area, which is outside the sacrum, if you just barely see this white line here, that's the sacrum, so it's anterior to that, so that's pre. And then on this MIP, or the whole body image, this patient's now turned. This is his nose, and he's looking to the right of the screen. And if you look down here, there's uptake right there, and that's what we're looking at. So this, and I think I have one more slide here to show you sort of zoomed in, is pre-sacral focal uptake of tracer on the PET CT. And this is a node that is positive. So again, that's a tiny little lesion. Conventional imaging would probably pass on that. We have nothing in the bed, nowhere else, and we have a singular recurrence showed in the pre-sacral space there. And so this next patient is coming in for restaging, and it's a 60-year-old male, and he's 1 year post-diagnosis of prostate carcinoma. And he was treated with systemic therapy. He already had metastatic disease. He was treated with systemic therapy. And then we did a gallium-68 PSMA-11 with, again, about 6 millicuries and 53-minute uptake. And so we show on this image, we're in bone window. Earlier images was mostly soft tissue, highlighting the soft tissues. But to see bone lesions on CT, you got to put in a certain window. So we're seeing these images. This is CT only. So these bright things are sporadic metastases. These are metastatic lesions, these bright white things. No lesions in there, and no lesions in this left iliac bone there. In the right acetabulum, lots of sclerosis. On the left acetabulum, looks pretty normal. So then we look at the PET images, and on the PET images, we'll see variable uptake. Like these dense lesions don't show much uptake. The lesions right here in the iliac bone here on the right and on the left show very mild uptake. But the lesion over here in the right acetabulum is very positive. It's very bright. It's almost bright, or getting bright as the urinary bladder there. And on the coronal image, you can see more of this uptake sort of variable through that right hemipelvis. So this is sort of showing osseous metastases with variable activity in this patient.
What does variability mean to you as you're reading this scan?
Sure. So that what that really means is we know that this lesion here that has a lot of activity is an active osseous metastasis. And the other lesions that we're seeing in the pelvis are treated or partially treated lesions. And if we had a prior study, it'd be nice to see that if these were very positive before, and now they're less positive, or were they always just sort of mildly positive? And if that's the case, then we have some lesions, and then we know that some metastases just have a different genetic or bio makeup that doesn't express the PSMA as well as other more aggressive lesions. And in the beginning, we talked about all the tumor grade and the higher Gleason score and the concentration of PSMA receptors. All that factors in. So it's either more aggressive disease or partially treated or treated disease is where I would come down and conclude if I was reading this PET CT and coming up with a conclusion. So good question. Thank you, Esteban.
Yeah, thank you.
So just highlighting again the variable activity in this. This is CT alone. This is the PET. The PET has some uptake in the iliac bones, not so much in the sacrum and these larger lesions there on that same patient. So our next patient, and he's being evaluated for lutetium-177 therapy. He's a 77-year-old male, diagnosed with prostate carcinoma and underwent prostatectomy, external beam radiation therapy, androgen deprivation therapy, as well as chemotherapy. And his PSA rises. And so we do the study, and we're looking at this patient here, and we look at it, and we see CT image, fusion image, again, coronal fusion, and sagittal fusion. And right here, we're looking at probably mid-thoracic spine, really not showing anything there. But the key here is if you look at the sagittal image right here, the patient facing towards your left, this is the spine going top to bottom. And if you look right here, there's a hot spot right there in the cervical spine. So that's a positive lesion for osseous metastases on this coronal. It looks like it's in the posterior elements there on the left. So that's a positive study. And now we're going to do a follow-up study. And when we do the follow-up, this patient underwent some therapy and was being evaluated for radioligand therapy. And what happens is, and what we see in this patient, again, up here in the cervical spine where we saw that lesion initially, is no longer present. However, now we see lesions elsewhere in the thoracic spine. That looks like vertebral body, that's posterior elements, the lumbar spine right here. So new lesions, maybe one in the left iliac bone right here. So we're seeing this. So it's a nice follow-up to show mixed response. And that's something that does happen in many cancers and tumors, but it does certainly happen in prostate carcinoma. We can see mixed response where one lesion we're following completely disappears, and we may see new lesions. Certainly in this patient, we have new spinal lesions. So let's look at one more sort of osseous metastasis. And so this is a patient who underwent PSMA PET-CT, and we see a large focus of activity on this PET image here, right? Then you have the fusion image down here, very bright orange. And the CT shows some sclerosis, some vague haziness there. You know, it's tough to tell if that's really a sclerotic met on the coronal. You see a little sclerosis there. It's probably that. There's probably some degenerative change, some osteophytosis there as well. But the PET is telling you this is very positive. It's a very high SUV just based on the intensity there compared to some of the background activity. So we're seeing a distant metastatic lesion, right? And the portions that we see elsewhere in the thoracic spine, the shoulders, skull base and cervical spine, elsewhere, nothing but this very hot tracer avid lesion in the cervical spine compatible with a metastatic focus. And same patient, just showing you again more of the spine here on the sagittal image. Very intense, very high SUV lesion in this patient here. Here is a 58-year-old male that's diagnosed with prostate carcinoma, underwent prostatectomy, and then his PSA bumps to 0.36. So that's when we get the PSMA-11 PET-CT. And again, I'll orient you. This is transaxial CT, sagittal, and coronal. The PET-only images, and then the fusion. So if we take this PET-only image, we got a very bright area here, but we localize it, and it's hard to tell in here because we're in bone windows, allowing the visualization of these osseous structures. It lands right in the urinary bladder. So that's okay. That's normal. That's where we always expect the tracer to go. But there's a small focus sort of in the, if you look at this as a clock, in the 1 to 2 o'clock position here. So now we're like, where is that? On the CT, it's hard to really see a lesion. The fusion gives it away, right? You look at it and you're like, okay, it's in the bones. This is the left sort of pubic ramus, probably the superior pubic ramus there. On the sagittal, we can see it there. Coronal, it's right there. So this is a osseous, isolated osseous metastasis at a low PSA. Again, remember, at 0.5 or 1, less than 1, we said about 50% positivity. Again, this would be one of those patients who had a positive lesion there, and it's an osseous metastasis in the left superior pubic ramus. So we have both that pubic ramus lesion on the left and the right anterior iliac bone in this patient with a very low PSA. So I think that's the cases I wanted to show you, some images and sort of history, and walk you through some local disease, metastatic disease, biochemical recurrence, the effects of treatment and mixed response. So let's just sort of get to the end of this presentation and tell you that the other thing that clinicians are very interested is sort of inter-observer variability, right? So if I'm reading the scan, and then the follow-up happened 6 months later, that whoever reads it after me agreed with what I said initially. That's just confirming the scan, the results that were given, the actions that were taken because of those results. That's something that's very important in any tumor, and especially prostate carcinoma. A paper came out in the Journal of Nuclear Medicine showed that overall, that the inter-observer variability was lower in gallium-68 PSMA-11. Another way to say that is that there was much higher intra-reader agreement, meaning if I read it and then 3 months or 6 months or a year later, someone read the same scan as a follow-up to say better, worse, or no change, there was much higher agreement with PSMA-11. So what about looking at who has supported PSMA PET imaging in the guidelines of taking care of our prostate carcinoma patients? And of course, we're at AUA recording and presenting this data and presentation. The American Urological Association, the Society of Urologic Oncology also agreed that for these indications, PSMA-11 is the agent and is the right examination to do for our patients under these conditions. So the confidence in PSMA PET imaging, we've got clinical accuracy. We're pinpointing micrometastases, earliest signs of recurrence or staging in small lesions. High quality images, we got to talk about it, told you about how small of a lesion we can detect. Then I showed you images that confirm and show you the power of PSMA-11 PET-CT, and also reliable distribution. We can order directly from more than 200 radiopharmacies with flexible scheduling and on-time delivery. And at the end, we also have end-to-end support, meaning industry-leading support for your practice through the Telix network of support. So from start to finish and continuing, I can show you the highlights of PSMA PET imaging and the confidence you can have. And then it's the most widely available radio tracer. Again, 99% on-time delivery with a network of more than 200 generators and cyclotrons. And it's not just the major academic centers, but also community health systems. And with the generator, getting it to smaller, more remote locations. And then gallium-68 delivers flexibility with high volume production via the cyclotron, or on-site, on-demand production if you need that with generators. So really efficiency of day-to-day workflow is sort of managed very well with the network that's established and the two available gallium-68 radiopharmaceutical agents we discussed today.
Thank you, Dr. Oza, for your presentation this evening, and certainly thank you to the AUA for the time to present PSMA PET-CT imaging of prostate cancer. There may be questions, and for questions, please go to telixpharma.com and simply click the Contact Us button and leave your comment, question, or concern, and someone from the team will get back to you as soon as possible. With that, Dr. Oza, I'd like to thank you and conclude this presentation and look forward to other presentations coming up in the near future. Thank you.